guys, I am Captain Anna Ferris, and today I'm going to be teaching you about caring for a trauma patient. I know that some of you guys, this is probably some repeat information, but I'm going to try to put everything together and just get kind of everybody on the same page. So with that, we'll go ahead and we'll go through general considerations for trauma care. So for the most part in a pre-hospital setting, there's kind of an algorithm for how you would conduct a rapid trauma assessment. So if you're just coming up on somebody, they have been identified as having a traumatic injury, you would first establish, is my scene safe? So, you know, look around, make sure there's no active shooters, make sure that there's no, you know, IEDs or anything in the area that could potentially cause harm to you and then whoever you're working with. Next thing, and this is especially, you know, pertinent given all the current events that we have going on today, BSI, so it's your body surface isolation. So do you have the appropriate gear to protect yourself from pathogens, from bloodborne illness, from you know, noxious gases, all of your CBRNE stuff. So just make sure that you're taking a quick intake assessment of what you're actually dealing with. Next, you're going to establish mechanism of injury versus nature of illness. So that kind of involves getting your chief complaint. So what happened to this person? And then you kind of formulate your plan of care from there. Number 3 and 4 kind of are specific to EMS, but you still want to kind of take an assessment of how many patients do I have? Do, you know, the number of patients kind of exhaust my ability to care for them? And do I need additional resources? For our environment, you know, that includes considering security forces, considering CCAT, do we need a burn team, do we need a NICU team? You know, consider your resources and try to get that set up ahead of time. Next thing, when you actually walk up on this patient is there a potential for them to have a C-spine injury? That's kind of the biggest thing that we can do in a pre-hospital setting to prevent a secondary injury that could cause them, you know, to lose life, limb, you know, ability to move down the road, and it really significantly impacts their quality of life just in that moment of time when you first arrive on scene. If, you know, you are not protecting their C-spine, you could be doing them more harm than good. So definitely think about that first, have that straight off, you know, in the top of your head. Get your initial impression next. So I like to call this sick versus not sick. So, you know, are they dying right now, or can they kind of hold on for a second, and, you know, can we do some interventions on scene? Number 7 is going to be your GCS or your AVPU, so assessing neurological function. I do this as simply as just being like, hey buddy, what's going on? So if they can tell you what's going on, chances are they have some recollection of, you know, who they are, where they are, what day of the year is it, and then kind of what's the situation, like what happened to them. Chief complaint kind of goes back up to your, you know, initial impression, but you want to just have a clear flow in your head for, you know, what exactly is going on, like identifying your life threats, and, you know, can they talk? If their GCS or their AVPU is, you know, not at baseline, like what does that require of you? What should you be thinking at that point? ABCs, so we all know ABCs. If you have taken TCCC, the biggest thing that they're teaching with that, and they're also teaching it on the pre-hospital side, if anybody's had like PHTLS, the start of that algorithm before you even get to your A, your B, or your C is massive hemorrhage. So do they have active bleeding? Is there something that we can put a tourniquet on? Because they're gonna die just as quickly from that as, you know, obstruction of airway or, you know, any of the other things kind of further down that you're thinking. So get the bleeding stopped. And then number 10, make a transport decision. Like, are they packaged appropriately? Are they ready to go? Do we have everything that we need? And just kind of wrapping up your on-site care and just making sure that you're getting in there and getting them ready to go and doing it safely. So again, as you are looking at your patient and you're doing your rapid trauma assessment, it makes sense a lot of times. It doesn't always work out this way, but generally you want to do a head-to-toe approach to actually assessing your patient. You know, you've done your AVPU, like for the most part, apart from like massive bleeding, a huge projectile coming out of their head, something like that, you know, do a good facial and head assessment. Go to the neck and, you know, make sure, is their C-spine where it needs to be? Do they have a tracheal injury? Looking at their chest, you know, do they have equal chest rise and fall? Do they have any kind of paradoxical movements? Checking your abdomen, is it rigid? Is it shiny? Is it hard? Is it extremely tender to touch? Is their pelvis stable? So if you're first one on scene, if you rock the pelvis, you can feel some of that crepitus, you can feel some of that instability. And the biggest thing, and this goes along with massive hemorrhage, is you want to tie it, you want to stabilize it, because you can lose a ton of blood. You can lose up to 3 liters of blood in a pelvis. So you want to really make sure that you're assessing that. And that's a one and done kind of assessment. If you get on scene and, you know, rescue or whoever, PJ, whoever happened to have first contact with that patient, if they tell you pelvis is unstable, believe them. Make sure that they have something to stabilize that pelvis. Don't go rocking it multiple times. That's something that you'll see a big mistake with residents, like at a lot of trauma centers. You know, we'll bring a patient to them and we'll be like, pelvis is not stable, and the first thing that they want to do is rock that pelvis, and it's bad news bears. Don't do it. And then next, you know, check their back. If it's appropriate, if you know, you can stabilize their C-spine and do a good log roll. You're looking for step-offs, you're looking for you know, deformities in the spine, you're looking for holes that don't belong there, any blood, bruising, deformities, like I said, step-offs, edema, pain, anything abnormally hard or abnormally squishy. So if it's supposed to be hard and it's smushy, that's usually a bad sign. You're looking for crepitus. A lot of times when you turn them, you may find subcutaneous emphysema. It looks like, you can kind of see almost little bubbles sometimes, and if you go to touch it, it feels like Rice Krispies underneath your fingers, and that means that air has gotten somewhere that it doesn't belong. So a popped lung, a tracheal injury, a lot of times that's a really significant finding if you come across subcutaneous emphysema. Whether they look super sick or not, if they have it, that's significant. So that's something to make note of. If they have something that moves that shouldn't, like a long bone, that's generally bad. And then if something doesn't move that should, that's also bad. Sometimes with dislocated, you know, hips and shoulders, they'll kind of be frozen. And that's just those muscles like cranking down on them, and you can't get it to get to a position of comfort. And it's a big indicator that there's a dislocation there. And then something that isn't there that should be, are they missing parts of themselves? Is there an arm that they don't have? Probably a good thing to make note of, and make sure that you're getting a tourniquet on it. Once you've gone through all that, once you're stabilized and you've made that transport decision, always go back and reassess. You know, did you tie a tourniquet? Sweet, that's awesome. Like, you did a big part of your job. However, you're not really fully doing your job if you're not going back and reassessing, because those things can spin down that little windlass. If you crank it down tight enough, a lot of times it just wants to fling back out. So make sure that whatever intervention you've done, you're kind of following up for. So ATLS is Advanced Trauma Life Support. This is something that you know, the physicians in emergency medicine and trauma take as a certification. Nurses that have ATCN, they take the didactic portion of ATLS with the physicians, and I highly recommend it for you nurses that are looking to kind of advance your practice and expand your role. It's a great course, and so it gives you a lot of really good information. They go through kind of this algorithm where you're going through A, B, C, D, E's. So, you know, everybody should be familiar with A, B, C, D. it's your airway, breathing, circulation. Disability is like your neuro assessment, so that's your ABFPU. Exposure is essentially getting people trauma naked. So you want to see if there's any holes there. You want to see if there's anything, you know, open or like sucking chest wounds. You want to see if there's something there that shouldn't be there. The biggest thing after that, after you've provided an intervention, is you want to go back and you want to cover them back up because you don't want to let them get cold. Variations on the same theme that kind of go through your, you know, algorithm. We talked about PHTLS, so the biggest thing is it's the same A, B, C, D, E, except they start their algorithm with X, which exsanguination. Hilarious. So that's what they go with there. TCCC, which you guys will all get hopefully, it's essentially the same thing. Instead of your D, you have an H, so your ABCs, and then your H is head, and they call it the March algorithm. So it's March because your first and foremost action is massive hemorrhage, so address that first and foremost. So one thing that they talk about a lot of times in trauma is the golden hour. So the golden hour, a lot of times is kind of a misnomer, but essentially it says that for the best chance of survival, a patient from the point of injury to the point that they get to an OR and get them on some cold hard steel to open them up and address whatever their traumatic injury is, you have like a 60-minute window to kind of do all that. It's kind of a relative term, and the kind of accepted terminology that they're going with now is that it's more of a golden period, and your kind of golden window of opportunity is determined by your mechanism of injury. So, you know, for patients that may have like a ruptured aortic aneurysm, they certainly do not have a golden hour. A lot of times it's like a golden 5 minutes. And, you know, some severe high C-spine injuries, a lot of times before that neurogenic shock has a chance to kick in, you know, your golden hour is far shortened. So you don't want to delay on these patients. You want to get them rolling and get them where they need to be, get them to an OR is the biggest take with that. So triage is hugely important for our environment in any kind of mass cal situation. You really want to be looking, you know, who's important, like who needs to go now. There's a couple different ways in the hospital. They utilize the ESI level in a lot of places. So there's a Canadian one. It's not really worth getting too into the weeds on it, but you're basically triaging based on your most critical, which is your level ones. That's like you're actively coding your massive injury patients, cardiac arrest patients are a level 1, and then all the way down to a level 5. A level 5 can be as simple as, you know, I stubbed my toe, or I'm really just here for a medication refill. So you're kind of categorizing patients kind of as they come to you. That's important for us as we're moving patients because, you know, we have like our priority patients, our urgent patients, and they try to kind of sort them out, but that is constantly shifting. And so you want to always make sure that you're reassessing, you know, who's sickest, who needs me the most. And in the pre-hospital setting, they use, it's called START triage. The S is your simple triage and rapid treatment. And it basically gives you a rapid physiologic and mental status evaluation. So that's your, you know, head to toe. And it evaluates respiratory status, perfusion status, mental status, and you base your patient prioritization of casualties you know, on who's the sickest and who do I need to get to first, like who will die without active intervention. There is actually a MUC triage scale. It's the Model Uniform Core Criteria. It's for mass casualty triage. It's consensus based. national guideline that recommends 24 core criteria for all mass casualty triage systems, now known as SALT. Sort, assess, life-saving interventions, and treatment and transport. So basically, you're getting a whole bunch of patients, kind of sorting them out by who needs me, who doesn't. You're doing a rapid assessment, and then you're doing just life-saving interventions, tourniquets, C-spine, C-collars, an airway if they need an airway, chest seal if they have like a sucking chest wound, and then you're doing just basic treatments, and then you are getting them where they need to go. All right, so not to belabor this too much, but just to kind of hit the highlights of what are you doing in that initial triage period. Like I said, chest seals, that's an immediate intervention that needs to get done, sooner rather than later. Manual airway opening, needle decompression of the chest if they need that. You can give administration of a chemical antidote. So if you have a patient that has had a chemical exposure, there's certain kits that I know there's one, the 2PAM kit, and it's for like organophosphate exposures. You're going to administer that rapidly in that kind of initial phase, so that you're providing them some kind of support before you actually are considering them stable enough to transport. And then external hemorrhage control is the big one. So make sure that you're assessing and you're identifying areas that could potentially be problematic, and you're getting a tourniquet and you're getting that hemostasis before you start moving. And then after a move, you make sure you reassess. They do make some handy dandy triage tags. These are for mass cows. So black tag, they're not going to make it. Are they decapitated? Do they have exposed brain matter? Do they have such a life-threatening injury that they can't be extricated and moved? Chances are they're going to be a black tag. They're going to take more resources than you have available to provide them with. If you can't help them, keep moving. Red tag is going to be your priority patient. You're going to get them moving, and if they need an airway, if they need a tourniquet, if there's something that you can provide immediately to help them, and they have the potential to actually go on, if they can get some kind of intervention done, that's going to be a red patient. So that's going to be your first patient out the door. So if you have a helo and they've only got a couple litter spaces, that's going to be a red guy. Your yellow patient is kind of your like walking wounded. They may have a broken arm or a broken leg. As long as they're not requiring like tourniquet intervention on that, if you can just splint it in a position of comfort and maintain pulses to that extremity, that would be your kind of walking wounded. That's your yellow. Your green patients, a lot of times when you come up on these MCI situations, your first action is going to be, if you can hear me talking to you, come to me. And if they're able to actually like come walking out to you, those are your greens. You wanna get them out of the way, and then you kind of address what you can from there. So as far as tourniquet placement goes, I've heard a couple of different kind of theories on this. I've heard to preserve limb, you want to put it further down. That goes against all the teaching that I've ever had in my career. I know from experience, when I've seen tourniquets placed lower down, especially forearm and lower leg, as they see like in this no-no zone, you've got two bones that actually run through there, and when you tie those down with a tourniquet, in theory those bones can splint open whatever the vessel is that's actually bleeding. So really the best way to maintain hemostasis is to get that tourniquet high and you get it cranked down tight, and you assess, did the bleeding actually stop? And after every movement, just going back and reassessing if that's actually the case. There's kind of a standard where if you're able to maintain a blood pressure distal to the tourniquet placement, I've always been told that you don't want to necessarily do that. You want to do whatever it takes to stop the blood, but there is a pop-a-clot pressure, and that's about 80 millimeters of mercury, and that's about what it takes to actually feel a pulse, so a distal pulse. If you're able to feel a radial pulse, chances are you have at least 80 millimeters of mercury going to that extremity. It's another good thing for shock to know, because if you can feel a pulse, if you don't have time or you don't have the ability to get a blood pressure, if you can find a distal pulse, chances are their blood pressure is at least 80. So generally that's enough to get you where you need to go. So there's kind of a theory of the triad of death, and this is in relation to trauma. It's also called the lethal triad. Basically, as your acidity increases, your body temperature decreases, it impairs your blood clotting. So, the main thing that we can do in an outside transport environment is maintaining body temperature. You can tremendously impact the burden of coagulopathy just by keeping a patient warm. That includes warming blood products if you're giving blood, warming fluids if you happen to be giving fluids. It's kind of a hot topic. So a lot of resources say, replace blood loss for blood loss and nothing else. You're just going to turn them into Kool-Aid if you give them IV fluid. The most recent iteration of ATLS that I attended back in December is now, after many years of saying absolutely no fluid, is now saying that a liter of fluid is actually advantageous before you get to blood. So I think of it as this: if you have no other option, if you have no blood product available, if you can give them something, if they're not able to maintain perfusion without some kind of a volume, it's not the worst thing that could happen to them. However, it would be important, if you are giving that, to warm it before it actually goes into their body, so that you're not actually exacerbating that triad of death and increasing that hypothermia. So, kind of like I said, how do you beat the triad? Main thing is stopping the bleeding. So, you want to stop the trauma in progress. If they're bleeding out, no matter what you do, they're only going to get worse. Keep the patient warm up your fluids, and then keep them covered so that they're able to maintain some kind of body heat, so that you're preventing those coagulopathies. As far as replacing losses, like I said, blood for blood when possible. If you have nothing else and they are crashing on you, and by crashing I mean, were they talking to you and now they're not? Did they have a radial pulse and now they don't? If you have no other option, give them some sort of volume. And so this is for all you fancy guys out there that like talking the talk. A big subject of conversation is the trimodal distribution of death from trauma. So it kind of categorizes what's an immediate death. So what's dead on scene? What can you help versus what can't you help? Immediate deaths tend to happen seconds or minutes after injury. Those are your huge head injuries. Those are your devastating spinal cord injuries. Those are your huge penetrating chest traumas. The early deaths is, that's something that we may have a little bit of control over as far as, transport decisions that are made. So those tend to happen minutes or hours after the injury. Those are the ones where if you can get them to an OR in time, within your, kind of golden hour, your golden period, those you can have a pretty big impact on early deaths. Late deaths tend to happen days or weeks after injury, and that's something that we absolutely have control over, because those are your sepsis patients. You know, make sure that you're using aseptic technique. Make sure that, you know, if you're putting in a Foley, you're doing it, you know, per the protocol, and, you know, you're not contaminating your lines, that, you know, you're watching your, you know, hub if you're injecting medications and stuff. So we can't prevent all of those, but, you know, if we can do something on our end to make sure that these patients we're not creating problems where problems didn't exist, that can have a big impact on late deaths. So one thing that I want to talk to you guys about is neurotrauma, because this is a big portion of our really significant traumas, and they leave people with a lot of lasting disability afterwards. There's multiple types of head injuries. There's penetrating. Those can be gunshot wounds. Shrapnel is a big one. Projectiles, again, kind of fall into that same category. There's blunt force head trauma. Those tend to have that kind of contra coup feature to them, and it's acute acceleration deceleration injuries. So especially in MVCs, you know, they hit a significant impact, and so that's your coup, and then as they kind of slide back, your brain shifts within your skull and it hits the back of your skull. So you've got a frontward injury, and then you have like a posterior injury, and so you wind up with kind of a multi-trauma, even though it's a single impact. There's another type of head injury called a diffuse axonal injury. That's a DAI. MVC rollovers, multiple mechanism. So like shaken baby syndrome is a big contributor to that, and it's just that multiple, like, repeated injury to the same area. Falls downstairs. Anytime that you have anything like that where it's just a repeated assault to the head, a lot of times you'll see those diffuse axonal injuries. Intercerebral hemorrhage, so you can have different types. There's intraventricular parenchymal injuries, and that's where it's actually not in like a discrete space in your head, but it's actually the blood is leaking into the cerebrum. There's different types of specific kind of head bleeds. You can have subarachnoid hemorrhage, you can have subdural hemorrhage, epidural hemorrhage, and then you get your intracranial hemorrhages. So as far as assessing your patient, there's a few things to kind of look for here. A big thing is pupillary response. Are their pupils equal, round, reactive to light? Are you seeing this? Because that's generally a bad day for that person. Are they fixed and dilated? Are they not constricting when you shine light into them? You know, and it makes a significant difference. I don't know if you guys are able to see it on your end, but the slide, that kind of illustration to your far right, gives you a pretty good idea of what you may see in, you know, different types of head injuries. So if you're getting a unilateral dilated pupil, a lot of times that can be cranial nerve compression. If you get bilateral dilated pupils, a lot of times that's a midbrain injury. If they're kind of irregular, if you have like one pupil that is not round, barring any kind of like penetrating eye injury or any history of like cataract surgery, a lot of times that can just be like an orbital trauma, and that's where you want to be, you know, kind of monitoring your interocular pressures. When you have a conjugate gaze deviation, so your eyeballs are just going up and it's like they're looking at a ghost in the corner, that's called a conjugate gaze. And a lot of times that is something that you find in a frontal lobe lesion. So if you have like a frontal head bleed, a lot of times you'll see that. Pinpoint pupils, in some cases, if they're not like an opiate overdose, you know, small little pinpoint pupils that don't react to light, a lot of times can be an indication that there's a pontine injury, and a lot of those don't have great outcomes. I've got up there a GCS score. I know this stuff is super hard to see from the slides, but I'm going to send this out to you guys in the form of like an email. One of the things that we assess in a pre-hospital environment, there's several like quick identifiers of strokes or, you know, sometimes like brain bleed. We typically will use the Cincinnati pre-hospital stroke scale, and so that kind of looks at 3 different features. You're looking for a facial droop, an arm drift, or abnormal speech. So that's always something to consider with your patients. Just real quick, not to kind of inundate you with a bunch of stuff, the Monro-Kelly doctrine has a lot to do with you know, the outcome of these. So I'll play this for you guys real quick.
Monro-Kelly Doctrine by Dr. Lisa Del Signore.
So the first thing I'd like to talk about is the principles behind brain swelling in terms of the Monro-Kelly Doctrine, which you may be familiar with. Essentially, this doctrine states that the cranial compartment is incompressible, so the volume inside is a fixed volume. There are 3 things inside the cranium that make up its volume: brain tissue, blood, and CSF. Because the volume is fixed, these 3 things maintain the equilibrium such that when the volume of one component increases, the volume of another decreases. For example, when a lesion such as an epidural hematoma adds to the brain volume, there are compensatory decreases in CSF and venous volume, as you can see here. However, at a critical point, the CSF and blood buffers are not able to compensate for changes in cranial compartment volume. That is, when the volume increases too much, usually at volumes greater than 100 to 120 mLs, the intracranial pressure begins to rise as well, as you can see here. At this point, the intracranial pressure begins to skyrocket with changes in intracranial volume. And what we're trying to prevent here is reaching that critical point where brain swelling increases so much that the intracranial compartment is unable to maintain its pressure. And this is important because the amount of intracranial pressure that we see is directly related to the cerebral perfusion pressure, which is the driving pressure the brain is seeing in terms of delivering oxygen and other key nutrients to it. And cerebral perfusion pressure is defined as the equation, as you can see here, mean arterial pressure minus the intracranial pressure. So for any constant mean arterial pressure, you can see that as the intracranial pressure starts to rise, your cerebral perfusion pressure starts to drop, which means that the brain will start to see less nutrients, less oxygen, which can have deleterious effects on the brain in terms of ischemia and cell death. And typically when we talk about managing cerebral perfusion pressure, we think about minimum targets by age. And we'll get into this in a little bit in a few minutes. But you can see here that less than 4 years of age, we try to target a cerebral perfusion pressure around 50 millimeters of mercury. And we're between 4 to about 10 years of age, we target around 60 millimeters of mercury as a minimum target. And greater than 9 years, we start to think of them more as like an adult and target cerebral perfusion pressure around 70 millimeters of mercury.
All right. So that's a big way that we kind of guide interventions with neurotrauma, is based on kind of that Monro-Kelly doctrine. It's sort of an abstract concept, but if you can kind of understand like what she was talking about, where it's a fixed compartment, if you have something that doesn't belong there, your brain tends to, you know, try to compensate by either getting rid of blood volume or CSF. So again, this illustration is just kind of demonstrating that process as well. So let's talk about penetrating head trauma for a second. So if you had somebody with a little tiny Eiffel Tower stuck in their head, first thing that you would do is stabilize the object. You're never gonna pull it out of place because that's again something you could cause more harm than good. So stabilize it where it's at. You want to elevate your head of the bed. As you bring their head up to at least 30 degrees, it increases the cerebral venous return, so that helps with that compensatory mechanism of decreasing the amount of blood volume that's actually occupying space in the cranial vault. So you also want to maintain a neutral head position, so you want to keep them in a forward alignment, because as they're off like this, suddenly they're not able to get the blood flow up through their carotids with the same efficiency as if you're maintaining a neutral head. Manage the airway. Chances are this guy is going to need some airway support. That's not a natural state for these guys, so always think airway early and often. A good rule of thumb when you're doing your GCS is if you get a GCS of 8, intubate. Obviously, if it's less than that, you should also probably intubate. Decrease agitation. So if the patient is going crazy on you, you want to give something for sedation. You want to try to calm them down, because as they're agitated, their ICPs are going to be going up and their cerebral perfusion pressures are going to be going down. And so that's just bad for business. Pain is another big source of ICP. Coughing is huge. Vomiting is kind of the biggest thing that we can try to mitigate in a transport environment. So I've seen patients that have ICP monitors. So they talk about like 7 to 10 as being like a normal ICP. I've seen it go up well over 100 while a patient's vomiting, and it's a very common reaction when you have a penetrating trauma or any kind of head bleed, that you'll see violent projectile vomiting. And like I said, you just wind up cranking their ICP. So anything that you can do to prevent vomiting is going to really kind of help them in the long run. Anticipate seizure activity. A lot of times these patients are going to seize. Their brain is just firing on all cylinders because it's wondering what the hell happened. So if you have any orders for, Keppra or any kind of anti-seizure medication, you want to give that prophylaxis before you actually remove them from the stable environment and bring them into the transport environment. Any penetrating injury should have antibiotics on board. Ceftriaxone is a big one. Gentamicin, a lot of times I'll give, but they cross the blood-brain barrier. So you want to make sure that they're giving appropriate antibiotics to manage that injury. And then kind of last resort, if your ICPs are out of control, the way you try to bring those down is, again, by decreasing the volume of the brain, because you're not a brain surgeon. You can't decrease the amount of blood that you have within that cranial vault until they actually go in and pop their top. So what we can do is kind of shrink the brain volume, essentially by dehydrating it. You do that with like 3% saline or mannitol. Tends to kind of pull the excess fluid from the cerebral tissue. So another type of penetrating head trauma is basically anything that breaches the cranial vault, whether that's the skull itself. So like a blunt trauma, essentially, that is penetrating into the cranial vault. This is a GSW. You can see the bullet fragments here. You can see some pneumocephalus where there's actually air. I don't know if you guys can see the black there, but that's like a little air pocket inside the head. Again, that's another thing to consider in the flight environment, because what happens to air is we get to altitude, it expands. So anytime there's like a note in a CT scan about pneumocephalus, be thinking this guy could potentially have a big problem in his brain when we get up to altitude. And also just be thinking about altitude restrictions and things that you can do to mitigate that. Types of skull fractures, there's open versus closed. You can have an open skull fracture, again, like what we saw with that pneumocephalus. One big indicator that they have a specific type of skull fracture is with basilar skull fracture. A lot of times they'll have some pretty telltale signs and symptoms of that. The raccoon eyes, where just all the way around they get that periorbital ecchymosis. You can get a halo sign. So if you happen to notice they have like a runny nose, if they have a known head injury, it's probably worthwhile to grab a piece of gauze and dab it to that runny nose. And if it separates out into a halo, like a ring where you have blood in the center, and then it kind of bleeds out into another ring, that's a good indicator that there's CSF. Another way that you can do it is if you had a glucometer, CSF tends to be really high in sugar, so it will actually test positive for sugar. It'll show, like an abnormal sugar level to it. Where if it's just blood, it, won't necessarily. Let's see, battle sign. If you kind of look behind their ear, you can see on that kind of mastoid area that they've got some bruising back there. That's another good indicator that they have a basilar skull fracture. So again, the coup contra coup is that acceleration deceleration force. Primary injury occurs at the point of impact, and that secondary injury comes with the inertia of the exertional force. Those are bad because they can result in a venous or arterial injury or both. So another thing too to consider with those coup contra coup is this is the inside kind of bowl of the skull. And there's a lot of really sharp, you've got your sphenoid there and your ethmoid sinus, and kind of where all that sella turcica comes in, it's super, super sharp, and as the brain slides up against that, it's a really easy way to lacerate cerebral tissue. Subarachnoid hemorrhages. Bleeding in the subarachnoid space between the brain and then that kind of membrane that covers the brain can be classified as a subarachnoid. It typically tends to take on this butterfly shape, and generally in medicine, like a butterfly shape in any form tends to not be a great thing. Especially in the subarachnoid, it means that they got a big problem there. A lot of times this is caused by unmanaged hypertension or a ruptured AVM, so an arteriovenous malformation. You can have like an aneurysm in your brain, and if that pops, a lot of times it'll result in a subarachnoid. Symptoms of a subarachnoid, if anybody tells you they have a thunderclap headache, it's just one that comes on all of a sudden. This tends to be a postcoital problem. So following intercourse, a lot of times right at that moment that person kind of gets there, they may fall backwards and hold their head, and if that ever happens to a partner of yours, call 911. It's not that you were that good, it's that they probably have a subarachnoid. Another thing too, nausea, vomiting, that projectile vomiting that I talked about, these patients tend to get that like in spades. They will be like the exorcist in the back of your rig. Torticollis is like neck pain. A lot of times they'll have like a stiff neck, and that's from meningeal irritation. They'll be extremely light sensitive too, so that's another thing to consider in the transport environment is protecting them from light, because as they have increased pain and agitation, it's going to also increase their ICP. So getting onto the DAI that I was talking about earlier, your MVC rollover, blast injuries, your shaken baby syndrome. These are shearing forces of the brain's long connecting nerve fibers, the axons. That's kind of your stuff. That's what gets you thinking. Those are your synapses, and those are like your long connections that you develop over time. When you have these shearing forces and it strips these axons, a lot of times these have really, really poor prognoses. They do not recover from this. Like if you have mushed out fourth grade, you're not going to get it back. A lot of times there's just total obliteration of visible structures. The brain literally just looks like mush in a CT scan. You can see it in here. Like this is what a normal CT scan looks like. You have, your sulci and your gyri. I'm sure I always say that wrong, but you can see you have like your ventricles, and you have all your little ripples and ridges in there. In a DAI, like I said, just absolute mush. So it's bad. With the subdural, these are venous bleeds. They tend to accumulate over time. They're slow. A lot of times you'll see this in elderly patients that fall that are on anticoagulants. You know, they'll fall, it'll seem like no big deal, and then by 5 p.m. grandma is, you know, not acting right. It's also common in alcoholics. Alcohol tends to have like platelet dysfunction effect, and so they're not clotting as rapidly. So, you know, they're drunk, they're doing stupid stuff, and, you know, they'll fall and hit their head, and because they don't have the same capacity for clotting, they'll get one of these venous bleeds. You'll see a gradual decrease in level of consciousness. Nausea and vomiting, again, is a common feature. Altered mental status can be really significant. They'll have difficulty speaking. A lot of times they'll present just like a ischemic stroke. You know, they'll have like a unilateral hemiparesis or hemiplegia that is slow to progress. It's not like a sudden onset, like they're slumped over in a chair like this 1 minute. You know, all of a sudden they'll be dropping stuff, and you know, that tends to be as that venous blood tends to accumulate, that's what'll happen. This again is kind of a slow bleed. When you see on a scan where it's dark like this, it means that it's not necessarily active bleeding. There's a couple little areas here that are lighter that may be kind of still tending to bleed, but this is all probably loculated in there, and they have to actually go in and clean this out. In this patient, you can see their midlines here. This is what's called a midline shift. This is when they've had a mass effect, and they're no longer compensating. Remember how I said where it's dark and it's kind of coagulated in there, you can see it. On this one, you can see this person has like multiple bleeds, but right here, you can also kind of see where the skull is impacted. This is what's called an epidural bleed. It's an arterial bleed, and they tend to follow a very distinct type of symptomology where they will have an injury, they'll have a brief loss of consciousness, they'll be totally fine. These are the patients that you find dead in like a bathroom somewhere, and mainly like out of embarrassment. Like they have that lucid period, they're like, oh God, that's so embarrassing, I just fell down the steps. And they'll go and they'll be like, I'm just gonna splash some water on my face and just make sure that I'm okay. Well, following that lucid period, they have a rapid decline. Like all of a sudden, they can be incredibly aggressive. These patients, we've had to knock down with a significant amount of sedative because they tend to just get like this super strength. They have no inhibition. They'll typically have unequal pupils because they've had that rapid increase in ICP. They'll have a rapid decrease in loss of consciousness, and so it's always a good idea if you hear, you know, injury, brief loss of consciousness, they were fine. You may want to tube them when they're fine. You don't want to be like intubating when they're aggressive. So plan for clinical course to be that they will not maintain that for very long. Like I said, often accompanied by a skull fracture, as you can see in there. If not treated early, they tend to have a poor prognosis as well. An intracerebral hemorrhage, there's different types. You can have the intraventricular, that's kind of what this guy is, where it stays in the ventricle. You can have an intraparenchymal, where it's actually kind of leaked into the brain fluid. You can have cerebellar. Those patients tend to have, you know, really significant balance issues. And you can have pontine bleeds where, you know, they have a difficult time like maintaining just their basic human functions like heart rate and respiratory status. So those are all bad, and a lot of cases those are not necessarily operable. So as far as managing a head bleed, again, it goes back to that Monro-Kelly. You want to try to maintain an ICP of 7 to 10. And you want to try to maintain your cerebral perfusion pressure. So your MAP minus your ICP is where you're going to get your CPP. So you want to try to keep that between 60 and 70. So biggest thing is, you know, preventing secondary injury. Don't let them get hypoxic. Don't let them get super hypotensive. Keep their oxygen saturation greater than 90% at all times. And then reduce those things that cause secondary brain injury: vomiting, pain, agitation. Keep your head bed elevated, keep your head in a neutral alignment. And then, when you start noticing symptoms of their ICP increasing, so like if they previously had equal round reactive pupils and now they have like a unilaterally dilated pupil, that's a big indication that their ICP is shooting up. And if you can get them some mannitol or some 3% on board, that would be helpful. So the point at which a patient is no longer compensating is when you have this Cushing's triad. I'll kind of spare you the whole video, but Cushing's triad is basically like they're on a collision course with death. Their brain is no longer compensating. Their Monro-Kelly is no longer able to keep them supported. So you'll see their systolic blood pressure shoot straight up. So you'll see like systolics greater than 200 a lot of times. I've seen 220, 230, 240. Heart rate will go down. So inexplicably, you'll see their heart rate drop in the 50s, then the 40s, then the 30s. At that point, it's bad. This is kind of rapidly evolving to a herniation point. You'll see a depression of the respirations. So like I talked about, herniation is the point at which the skull just can no longer accommodate the swelling, and the brain finds any way out that it can. So that's called herniation. There's a couple ways that it can go. It can go through this foramen magnum. It can go out defect, like in a penetrating injury. So you can have different types of herniation. You can have uncal herniation. That's where it kind of comes out that foramen magnum. You can have tonsillar herniation, but they all kind of present in a somewhat similar way, where you get that Cushing's triad and you're just kind of chasing. At that point, your only hope is to actually get the skull opened up to give the brain more room to swell. So very similar to head injuries, you manage eye injuries quite a bit in the same way. Your interocular pressure tends to follow the same parameters as your intercerebral pressures. So again, if you have a projectile type injury, the first thing that you want to do is stabilize that injury, and then you also want to cover the unaffected eye. So it doesn't always make sense, like why would you cover the good eye? Like at least give them, some sense of their surroundings so that they're not completely like sensory deprived. But your eyes, move together unless you've had a very serious injury. As your good eye moves, it's just going to keep moving that eye with the projectile in it. So make sure you're covering both. Maintain a head about 30 degrees, neutral spine. Don't put any pressure on the affected eye. And let's see, anything that would increase intracranial pressure is also going to increase interocular pressure. So your vomiting, your pain, your agitation, make sure you're managing those. A big thing that they tell you too with eye injuries is if a patient has to sneeze, you want to try to prevent it. That drastically increases your interocular pressure, but if there's no preventing it, make sure that they're sneezing with their mouth open. Like as you see it kind of coming on, just be like, if you have to sneeze, make sure you keep your mouth open because you'll hurt your eye if you close it. And that tends to be very true. So it helps to kind of distribute some of the force if their mouth's actually open. So as far as eyes go, there's a significant secondary injury from G-forces, vibration, decreased humidity. Obviously, it's just going to irritate that eye more. Changes in barometric pressure, especially if they have like a penetrating eye injury. Those are ones that you want to ask early for an altitude restriction. Assist in ear opening without having the patient Valsalva. Make sure you're giving Afrin and decongestants unless there's some kind of contraindication to that. So chemical burns. So I really apologize to you guys. I hate eyes. It's like my one get. I see an eye injury and it's like some people have ortho, some people have like different things that bug the crap out of them. I hate this stuff. It freaks me out. But chemical burns, the biggest thing with that is irrigation and lots of volume. So you want to get, like 2 liters of volume through this eye if you can. Generally, they have a device called a Morgan lens, and it looks just like a contact, and it hooks up to a saline bag. You can actually put that, and it provides, kind of a controlled, continuous flow of irrigation through tubing, through like an IV tubing, and you just hook up like a normal saline bag, some IV tubing, the Morgan lens. The only thing with that is, in the case of some of these chemical burns, especially something like that, if it's already causing damage to the eye, the trauma of actually putting that in there may be contraindicated. So that's, kind of something for the doc to determine. The other thing too to consider is tetracaine drops and giving them something that's going to help numb the eye to control the pain so that they can tolerate the irrigation process. Especially in chemical burns, alkaline burns tend to be a lot more detrimental. They cause a lot more tissue damage than acid burns. So make sure with alkaline burns that you're getting lots and lots of fluid through there. Dry powders tend to be a lot more damaging as well than splashes and liquids. Flash burns from like arc welding or like a blast injury. The biggest thing for treating those is keep the eyes closed, protect them from light, and keep them moist. Ruptured globe, again, horrible, bugs the crap out of me. I have seen it on several occasions. You get this irregular pupil. That's a big indicator that you've got a globe injury. They tend to have a poor prognosis for saving the eye. It can happen, like skilled ocular surgeons sometimes can salvage the eye, but a lot of times they wind up with an enucleation. So again, the biggest thing is managing your interocular pressures. Make sure that they've got some antibiotics ordered. Make sure that they've got an up-to-date tetanus. And let's see. Make sure you're also, giving nausea medicine because the disorientation from that changing pressure can make them nauseous. So blast injuries. There's 4 different types of blast injury, and they all have to do with kind of distance and where the blast took place. You can have a primary injury, a secondary injury, a tertiary injury, and a quaternary injury. And it tends to kind of indicate where you were at the time of a blast. So passengers in a vehicle hit by an IED, it's common to sustain both a primary and a tertiary injury because you're in an enclosed space and you're also kind of getting that stuff thrown at you. So they tend to have head injuries a lot of times. They tend to have other traumatic injuries that go along with it. Blast injuries. So besides the polytrauma that comes with, the multiple forces, blast injury patients are extremely susceptible to hollow injury or hollow organ injuries such as pneumothorax. You can rupture your stomach, your bladder, your tympanic membranes. A big indicator, if you kind of come up on a scene and these guys are just saying, I don't know what happened, like we just rolled over and they're found a long distance away. A big indicator that there was a blast associated with this MVC is if they have blood coming from their tympanic membranes. A lot of times intestinal rupture will occur from just that rapid overpressurization in the cabin. Another clinical feature of a blast injury is something called a blast lung. They tend to show up in a chest x-ray, again in a butterfly pattern, and it's a classic kind of diagnosis that can lead in a lot of cases to ARDS and like more significant pulmonary injury problems. So that's a picture that's kind of that, you know, butterfly shape of the blast lung. So as far as treating burns, one thing that was surprising to me, you know, in nursing school I only learned about your 1st degree, 2nd degree, 3rd degree. There is actually a 4th degree burn. I've seen it, it ain't pretty, but when you're burned to the point where it actually gets down to bone and underlying structure, that's when you start getting into 4th degree. Your 1st degree is like a sunburn. It's not calculated in TBSA. They're painful but not life-threatening, and it just affects the epidermis of the skin. 2nd degrees are those that get calculated into the TBSA. They affect the deeper layer at the dermis, and they tend to have some underlying subcutaneous tissue involvement. They're painful because the nerves remain intact. If they have blisters like this poor guy, try to leave them intact at all costs, because it's going to help to kind of insulate that area, and it's going to prevent infection, at least while they remain intact. Your 3rd degrees, this yellow is actually very accurate. I've seen that a lot of times. In these cases, the burn extends through the epidermis, dermis, and then into the underlying structures like your nerves, your blood vessels, your muscles, etc. They have like that yellow, waxy, sometimes white, blanched appearance to them. A lot of times they're charred like that. They tend to have massive fluid losses because their skin is not maintaining their fluid balance. Very high risk for infection as well. A lot of times these patients will walk over to you and they'll just be like, I know that this is bad, but you know, I can't feel anything, and they literally don't. And a lot of times when they get to the burn center, the first thing that the burn surgeon will do is they'll just start stripping skin, and they don't even feel it. It's painful to watch, but doesn't actually hurt them like you'd think. So this is what I was talking about, where it gets into the bone. It's a 4th degree burn. These again tend to have a very poor prognosis. Electrical burns are an interesting kind of burn because they are burning you from point of entry to point of exit. So, you know, if you get burned here and it comes out here, pretty much everything in here is included in that burned area. So this may be all you see. And this guy could actually have just a massive internal burn as well. A lot of times you'll get dysrhythmias. You'll get on scene after a electrical burn, and they'll be in VTAC. The biggest thing with those patients is if they are not responsive after an electrical injury, slap some pads on them, check a pulse. You want to follow your algorithm for ACLS, but you want to defibrillate early because you want to get them out of that rhythm. These patients need lots and lots of fluid, because as that electrical impulse has traveled through all their muscles and everything, you get huge destruction of your muscle cells, and you get what's called myoglobinuria. And so when you pop a Foley in these guys, a lot of times it tends to look like Coca-Cola, and that's that myoglobin coming out in their kidneys from their damaged muscle tissue. It is a very large molecule, and it clogs up the kidneys. So these patients a lot of times will progress to renal failure. So the biggest thing is, you know, making sure that you're flushing them with fluids and trying to get that myoglobin through it. A lot of times they will tell you to titrate your fluid to clear urine. So that's the goal, is to kind of flush it out so that you're not getting that brown tea-colored urine. These patients also tend to have a lot of hollow organ injury. We had a patient one time that he and his son both actually got an electrical injury, and it essentially popped all of their hollow organs. So their stomach, their large intestine, small intestine, bladder, both their lungs, it was all open. They were not in good shape when they came to us. Again, lightning is a source of electricity. You probably can't see it from here, but again, I'll send the slides out in an email. They tend to leave this kind of like lacework pattern on an extremity or from their point of entry. Electrical burns from lightning have just an absolutely massive amount of energy. Cloud to ground lightning, let's see, it's a common phenomenon. About 100 strike the Earth's surface every single second. Let's see, each bolt of lightning can contain up to 1 billion volts of electricity. So there's no such thing as like just a mild lightning strike. Like these are bad. So with burns, the thing you want to be thinking about is fluid resuscitation. So calculating an accurate TBSA is essential for managing these patients. Anybody with a TBSA greater than 20%, either second to fourth degree burns. So again, that first degree doesn't calculate out into your TBSA. But for those patients as well as electrical burn patients, use the rule of tens for fluid resuscitation. Rule of tens for patients 40 to 80 kilograms, use the formula 10 milliliters per hour times your percent TBSA. For any patient greater than 80 kilos, add 100 mLs per hour. So again, this is all in your AFIs. For electrical burns, because their TBSA doesn't really indicate the extent of their injury, your goal for those guys is going to be to keep your urine output 70 to 100 mLs per hour. And the biggest thing is always make sure that you're reassessing your patient as you provide them with fluid. Make sure you're looking at their work of breathing, assessing lung sounds if you're able to. Make sure that you're not fluid overloading these patients. As far as caring for the burn patient, you're never going to change your dressing in flight. The biggest thing is just to reinforce, and a lot of times at a burn center, they'll put on antibiotic ointments followed by like a layer of Zeroform gauze, dry sterile dressing, and then like some kind of tape to keep it on there. In our environment, if we're coming up on them for the first time, the biggest thing that American Burn Association wants pre-hospital providers to do is to just put a dry sterile dressing on there. And another thing to consider is getting your checking on your tetanus status and making sure that they've got an up-to-date tetanus. Hypothermia is big because they can no longer thermoregulate. You think about how do we thermoregulate? Like we sweat, and we have like body hair that you'll get goosebumps and stuff, and they really can't effectively do that if their skin is burned. So the biggest thing is monitoring core temperatures, trying to maintain what body heat they do have, and then provide active warming. So as far as when you need to call for help, severe burn criteria according to AFI 48307-1, attachment 10 is for any patient with second degree burns more than 10% TBSA, burns to the face, hands, feet, genitals or joints, or circumferential burns, third degree burns, electrical burns, chemical burns, inhalation injuries, polytrauma, peds, any kind of psychosocial type issues, and patients with complicating comorbidities, diabetes, CHF, COPD, definitely worth looking into whether or not you can get a burn team to come with them. So big thing with these patients, get 2 large bore IVs, 18 gauges or bigger in them, Foley, NG tube, not exactly sure why, but get them an NG tube, make them more uncomfortable. Consider airway. So if, especially in like blast injuries, there's a big likelihood that they've had airway injury as well. So assessing that, because that can swell and get out of hand really quickly. They're very high risk in circumferential burns for compartment syndrome. As that skin kind of contracts down, it creates a compartment. It's almost like a tourniquet, but it's allowing blood in, but not allowing it to flow back out. And so it can quickly kind of overwhelm that sheath around the muscle and cause compartment syndrome, and they can lose a limb pretty quickly that way. Aspirotomies are something that are done by the docs. We're able to do them in some capacity to patients that have circumferential chest wounds, or chest burns. If we're not able to ventilate them effectively, if we've got really high peak pressures, a lot of times we'll cut an aspirotomy, and it is kind of, you're going down one side, coming back up to the xiphoid process, coming down the other side, and then coming up that mid-axillary line again, and it just allows for the lung expansion so that you can actually ventilate your patient. All right, you guys made it. Good job. Thanks for sticking with me, and I'll get you guys out slides so that you can follow along. All right, thanks, and have a good UTA.